Hello guys, welcome back to Clinically Clear. Today we'll be covering a few more important short topics with respect to cornea. So let's start with the first one. This is a 3-mark topic or max 5 marks topic. I've not put all the points required. I've put like just some points that can fetch you a decent amount of marks. So first let's start with Acanthamoeba keratitis. It is caused by a protozoan named as Acanthamoeba castellani. Now, how does it spread? Most of the times it spreads from contaminated water. From contaminated water through diving in contaminated water, washing contact lenses in contaminated water, your bathtub has contaminated water. These are the way it spreads. Then some characteristic lesions. Here also you will have pseudodendritic keratitis. What is pseudodendritic keratitis? You have zigzag lesions on the cornea with tapering ends. It is pseudodendritic. True dendritic is in herpes simplex virus. Pseudodendritic is in Acanthamoeba keratitis and herpes zoster ophthalmicus. Then Acanthamoeba keratitis, you have severe pain. Why is it? Because of a condition known as radial keratoneuritis. Some neural something is involved, so there's a lot of pain. So radial keratoneuritis. And another classical feature in the stroma, what you can see is ring abscess or ring infiltrate. You have a infiltration of some pus or some inflammatory infiltrate, even I don't know, but basically it is in the form of a ring abscess or ring infiltrate in the stroma. And when you culture it in, where do you culture it? You culture it in non-nutrient agar enriched with E. coli. This is an MCQ question. And when we culture it, you can see in the microscopy that you can see the double-walled cysts of Acanthamoeba castellani. That is the microscopy. And treatment, you have two special drugs. One drug to inhibit the membrane function, that is polyhexamethyl biguanide, and one drug to inhibit the DNA function, that is propamidine. Polyhexamethyl biguanide is the drug of choice. So Acanthamoeba keratitis, that's all. Acanthamoeba keratitis, protozoan Acanthamoeba castellani, contaminated waters, diving, bathtub, washing contact lenses, 3 specific lesions, pseudodendritic ulcer, radial keratoneuritis causing pain, and ring abscess or ring infiltrate in the stroma. I'll culture it in non-nutrient rich agar enriched with E. coli, and when I do microscopy, I'll see the double-walled cysts. I'll treat it with 2 special drugs. Drug of choice, polyhexamethyl biguanide, which inhibits the membrane function, and the other one is propamidine, which inhibits the DNA function. That's it. Next, coming to exposure keratitis. Now, what is exposure keratitis? It is also known as lagophthalmos keratitis. Basically, what happens is patient has lag of thalmos. What is lag of thalmos? Patient is unable to blink or close the eyelids. And we know that closure of eyelids, blink reflex, is very, very important in keeping the cornea moist. So when the cornea is not moist, what happens? The cornea gets dried up, right? So in lag of thalmos, patient is not able to close their eyelids. So the cornea is completely exposed to the drying effects of air. So this causes drying and desiccation of the cornea. And when there is corneal xerosis, we know that it is a risk factor for bacterial ulcer. So secondary infections can happen leading to corneal ulcer. Now, that is why it is due to lag of thalmos. What could be the cause of lag of thalmos? It could be physiological lag of thalmos. Patient just keeps their eyelids open when they are sleeping. Many people have this. Then it could be severe ptosis. The patient's eyelids are drooping so much that the patient is not able to close the eyelids. It could be because of symbolpharon, adhesions between the eyelid and the bulbar conjunctiva. That could lead to lag of thalmos. And Bell's palsy. We know that for closure of eyelids, we need to use orbicularis oculi, which is supplied by the facial nerve. And facial nerve palsy will lead to lag of thalmos. Why? Because now the orbicularis oculi is paralyzed. So these are some of the causes. Symptoms due to the infection that I told. It predisposes to infection. So due to the infection only, you'll have a lot of symptoms. But with respect to the exposure, what happens, especially in the morning? Why in the morning? Because throughout the night, drying effect. Especially in the morning, burning, itching sensation, redness, watering, and a lot of irritation. Severe symptoms. That is in the morning. Signs, what you'll have? You'll have signs like drying of the cornea, of course. Then you'll have epithelial defects as a transverse band. Why as a transverse band? Basically, this is your eyeball. Your eyelids, even when they're, okay, let's say they're not completely closing, they'll still block some of the eyeball. They still cover some of the eyeball, right? This part between the eyelid that is exposed, between the two eyelids that is exposed, that is known as interpalpebral fissure. So epithelial defects are seen in a horizontal band corresponding to the interpalpebral fissure. Then another sign could be the corneal ulcer itself due to the infection. How will you treat it? You should treat the cause of the lack of thalamus. That is, you should treat the cause of the lack of thalamus, and you should also frequently instill artificial tears. When you frequently instill artificial tears, it will prevent excessive drying. You will give soft bandage contact lens for symptomatic relief, and you will tape the eyelids. You will ask the patient to tape the eyelids together when sleeping to prevent excessive exposure. And you should also remember to treat the corneal ulcer that has come as a complication of exposure keratitis. So, what is exposure keratitis? Also known as lack of thalamus keratitis. Etiology could be anything causing lack of thalamus, Bell's palsy, severe ptosis, then this thing, what? Oh my god, even I forgot. Bell's palsy, severe ptosis, symbol furon, and then this and another one. What was it? Physiological lack of thalamus. Then you have pathogenesis. Pathogenesis is basically what happens due to lack of thalamus. Patient is not able to close the eyelids, so there is excessive drying and exposure. That can lead to predisposes to infection. Then symptoms are due to the infections, and in the morning especially you will have all this burning, itching, redness. Signs are corneal drying, epithelial defects in the form of corneal band, and bacterial corneal ulcer due to the infection. Treatment: you will tape the eyelids, you will give artificial tears, you will correct lack of thalamus, you will treat the bacterial ulcer. Then coming to the next topic, that is corneal edema. See, corneal edema, basically normally our cornea has 78% of water. So this corneal edema is essential because intraocular this hydration state of cornea is essential, being 78%, because anything more than 78% it will decrease the transparency. We know that intraocular pressure is trying to push the aqueous humor into the cornea, so that tries to increase the water content, whereas the endothelial barriers and the endothelial pumps, they try to draw out water. So this fine balance is important to maintain a relatively dehydrated state of cornea. So what could be the etiology of corneal edema? It could be increased intraocular pressure. It is pushing too much water inside. That is glaucoma. It could be endothelial dysfunction. Endothelial dysfunction could be because of any endothelial injury, such as birth trauma, surgical trauma, or any penetrating injury, or it could be because of endothelial inflammation, like her HSV endothelitis. It could also be because of epithelium injury like mechanical injury, chemical injury, thermal injury, etc. This is the etiology. Excess IOP, increased IOP, endothelial defect, and epithelial defect. When there's endothelial defect, endothelial normally acts as a barrier, right? It prevents aqueous humor from entering the cornea. But now endothelium is injured. When epithelium is defective, tear film water starts entering the cornea. So corneal edema. Increased IOP, increased IOP, so increased aqueous humor pushing into the corneal endothelium, it will eventually lead to corneal edema. So that is the cause. Symptoms: initially you have haziness. Initially, see, transparency reduces, of course. So haziness, colored halos. Why? It acts like a prism. The water in the corneal edema, it acts like a prism. It splits the light into different colors. So patient sees with gear the rainbow colors upon looking at a point source of light, etc. That is colored halos. Then later on, if this corneal edema is long standing, prolonged, then what happens? It leads to something known as bullous keratopathy. Now, bullous keratopathy not only causes permanent corneal edema and permanent loss of vision, it can also cause pain because of rupture of these epithelial bullae. Rupture of these epithelial bullae can lead to pain. So these are the symptoms. Initially, haziness, colored halos, transient loss of vision, long-standing bullous keratopathy, permanent edema. Treatment is, first of all, you should treat the cause of the corneal edema. Whatever the glaucoma, you have to treat the glaucoma. Any HSV endothelitis, you have to treat that. Any epithelial, chemical injury, mechanical injury, thermal injury, you have to treat that. So treat the cause of the corneal edema. Then try to dehydrate the corneal edema. How will you do that? You'll add hypertonic saline, 5% hypertonic eye drops. You will use a hair dryer and you'll blow hot air into the cornea. You can try that. All that doesn't work. It is a long-standing case of corneal edema. It has reached almost bullous keratopathy. It has become bullous keratopathy. Then you have to go for corneal transplantation or keratoplasty. So corneal edema normally should be 78% H2O. If it's more than that, transparency reduces. Intraocular pressure is trying to push water out. Corneal endothelium is trying to pump the water out. Intraocular pressure is trying to push the water into the cornea. Corneal endothelium is trying to pump the water out of the cornea. And then eventually what happens? when there is increased IOP, endothelial dysfunction because of either inflammation or injury or epithelial injury, then there is corneal edema. Long-standing corneal edema will lead to bullous keratopathy, epithelial bullae formation, rupture, pain, all that. How will you treat it? Treat the cause of corneal edema, try to dehydrate the corneal edema, and in case of bullous keratopathy, you have to go for keratoplasty. Then, next coming to some conditions known as PUK, peripheral ulcerative keratopathies. Peripheral ulcerative keratopathies mainly include three things: peripheral ulcerative keratopathy with connective tissue disorder, then Murren's ulcer, and you have rosacea keratitis. So peripheral ulcerative keratopathy with connective tissue disorder, Murren's ulcer, and rosacea keratitis. So what happens in peripheral ulcerative keratitis with connective tissue disorder? What could be the connective tissue disorder? It could be rheumatoid arthritis, SLE, it could be polyarteritis nodosa, etc. Clinically, what happens? First, it starts as peripheral corneal epithelium thinning and melting. Then there is guttering of this cornea. Guttering of this cornea, what happens? It appears as if there's a gutter in the peripheral part of the cornea. So within the gutter, it appears like as if it's a contact lens. Think about it. There's like the cornea is like this. There's a small gutter, and then again the cornea comes up. So the part that's inside, it appears as if it's a contact lens placed on the cornea. So it is also known as contact lens cornea. And eventually there can be ulceration also, peripheral corneal ulceration, peripheral acute corneal ulceration. These are the clinical features. So treatment, what you will do here, you can give topical drugs like lubricants, atropine. You can give topical steroids. Not topical steroids actually will cause epithelium thinning, so you won't give topical steroids. You can give topical lubricants, topical atropine, topical medication. You can give systemic medications to decrease that connective tissue disorder. You will give immunosuppressants like cyclosporine and methotrexate. You will give vitamin C to promote collagen cross-linking and to heal the corneal guttering and the corneal ulceration. And you can even do surgical therapy such as soft bandage contact lens and tissue adhesive glue such as cyanoacrylate. You will apply onto that ulcer, you will put soft bandage contact lens so that there is support to that peripherally thinned out cornea so that it does not perforate. What we want to do, we want to prevent the perforation of the cornea. This connective tissue disorder is leading to thinning. We want to suppress that connective tissue disorder and we want to prevent the perforation of the cornea. So that is about peripheral ulcerative keratopathy with connective tissue disorder. So what is it? SLE, rheumatoid arthritis, polyarteritis nodosa. What happens basically? Symptoms: peripheral corneal epithelial thinning, peripheral corneal epithelium thinning, peripheral corneal epithelium guttering, where it appears like contact lens cornea, peripheral corneal epithelium ulceration, acute ulceration. Treatment is topical medications such as lubricants and atropine, systemic medications, immunosuppressants like cyclosporine and methotrexate for the connective tissue disorder, vitamin C to promote collagen cross-linking to promote healing, and surgical measures such as soft bandage contact lens as well as tissue adhesive glue such as cyanoacrylate to prevent the perforation. This is about PKU with CTD. Then there's another very important one, Murren's ulcer. This is a very severe form of peripheral ulcerative keratitis. Did I say PKU? PUK, peripheral ulcerative keratopathy. Then here the etiology is autoimmunity against the corneal epithelium. So autoimmunity against the corneal epithelium destroys the corneal epithelium. It can be of two types: unilateral, benign, non-progressive, or it could be bilateral, virulent, and highly progressive. Symptoms are, just think of corneal ulcer symptoms: pain, photophobia, watering, irritation, foreign body sensation, blurring of vision, everything you put off. Then these are the symptoms. Then come to the signs. Signs, initially you have small peripheral gray ulcerative patches. So these small peripheral gray ulcerative patches, they eventually coalesce, and when they coalesce, they form a large peripheral ulcer over the large peripheral ulcer with overhanging white edges. These overhanging white edges or white margins are characteristic of Murren's ulcer. So initially small gray white ulcerative patches, then which coalesce to form a large peripheral corneal ulcer with overhanging white margins. How will you treat it? You will give topical steroids, topical steroids, and just immunosuppressants like cyclosporine and methotrexate. Why? To reduce that autoimmune reaction. You want to suppress the immunity. and you'll give soft bandage contact lens for support and to prevent perforation and all that. So Murren's ulcer, severe form of peripheral ulcerative keratopathy, where you have autoimmunity against the corneal epithelium. What happens here? Two forms: virulent, progressive bilateral, unilateral, non-progressive benign. Uh, Symptoms are basically pain, photophobia, blurring of vision, etc. Signs are small gray white ulcerative patches which coalesce to form a large peripheral corneal ulcer with overhanging white margins. Treat it with topical steroids and immunosuppressants to suppress the immunity and to reduce the autoimmune reaction, and soft bandage contact lens to support the cornea and to prevent the perforation. That is it. There's a long video, I know, but I've covered a few important topics. I hope you guys enjoyed it. Thank you for watching.